Good evening, sir. I hope you can hear me well.
Greetings. Yes, I can hear you.
Okay, so we'll wait for 10 minutes more. The session will start at 6 IST.
That's good.
Thank you, sir. Greetings, everyone. Thank you so much for joining in the session. I guess, sir, we can start with it.
Okay.
It's already 6.
Okay. Let's go to. Okay, greetings to everyone. So our session this month is on Module 5, Inventory Management. And just a few housekeeping announcements. As always, please turn off your mic and turn off your video to maintain bandwidth. Please ask any questions using the chat box or during the Q&A session by raising your hand on the little icon. You can ask questions at any time by typing them into the chat box. When you're invited to speak, please unmute and also turn on your video. The recording of this webinar will be available to you on the Empower School channels. The slide deck will be shared with all participants. So the main objectives of these webinars is to give you a chance to ask any questions, and we'll try and answer those questions. And today we have 2 sessions, but we're going to start with a presentation just to set the tone for inventory management. So we're going to start right now with housekeeping, then into a presentation for 20 minutes on how procurement and inventory management are interlinked together. Then the first Q&A session, then the key factors in inventory management, and then a longer second Q&A session. Again, please type your questions at any time in the chat box and we'll try and get to them during the Q&A sessions. I'm sure by now you're all familiar with my voice. You've heard it often enough. So I'm one of the people that wrote the Yellow Book, that's Managing Drug Supply and World Health Organization, and the E-Handbook of Health Systems. And most recently, I've written the WHO COVID training modules for supply chain of health commodities to address the COVID pandemic. Okay. So this inventory management, it's relatively simple and straightforward. All we've got to do is order the goods, receive them, put them in a store and issue them out. What's so difficult about that? But in many low-income countries, in public health, it fails to perform. That's not a feature of the country or its economic level. It is a feature that too often procurement and supply chain management is not allowed to perform. It's prevented from doing its job, often by archaic working practices, some of them inherited from the colonial era period. They're just 100-year-old practices. They've never worked very well, and they don't work well now. And somehow we've been stuck with them. And we have to try and change that. But in order to do that, we need some strong evidence of what's happening and what changes do we need. The comparison is often made. You can get Coca-Cola in every village around the world. How is it we can't get our medicines there? How is it that we are incapable of supplying the medicines? And the answer is often because we are prevented from doing it. It's not that we don't know how to do it. It's these archaic working practices that lock us in to a system which doesn't allow us to perform well. These obsolete systems are more than 50 years old. They weren't very good at the time. They came often from colonial activities and governance, and they were run for the convenience of the administration, not to address the health needs of the patient. Modern procurement supply chain management has a completely different ethos. Our whole reason for being is to address the healthcare needs of the patient, not to address administrative convenience. So we need a different set of rules and procedures to the ones we've been using. And it's not just old Prof Andy that says they are archaic procedures. You'll see that on the screen the references to many documents, and Prashant Yadav in particular has often written on this subject about archaic systems which are holding us back and preventing us performing. We must start by recognizing that the whole of the procurement supply chain is interconnected. It's all interlinked. What we do in procurement affects inventory management, and what we do in inventory management affects procurement. At its most basic, more frequently I buy, the less stock I have to hold. And for inventory management, if I have poor stock data, I'm never going to get accurate forecasts, and I'm never going to order and procure the correct amounts that I need. These two interlinks are really important, and we have to recognize the whole of the supply chain is interlinked. Too often, inventory management and warehouse in particular has a silo mentality. It's we do our job, you do your job, and that's it. You cannot. Procurement and inventory management are interlinked, intertwined, interconnected. They affect each other. And in recognizing that, we then start to understand some of the problems and difficulties that we face. Fundamentally, inventory management is about achieving a balance. One of those balances is on cost. As I order larger quantities for longer periods of time, the cost of my ordering on this graph, the blue line, the ordering costs reduce. Bulk buying is cheaper. If I were to buy 3 years' supply at one time, I would get a lower price than if I'm buying 1 month's supply. That's an effect of the marketplace for all items. So if I increase the order size, I reduce the ordering costs. But if I increase the order size, I've got more stock. So my cost for holding that stock, for having that stock in the store, increases. And that's the red line. We can see as the procurement costs come down, the holding costs go up. And if I look at the total cost, the green line, we get to a place which we call the economic ordering quantity. And that's the best amount to order. That's when all the costs are in balance. Now, there are other factors than cost, and we'll come to those shortly. But for now, let's just look at cost. How many of you have ever made that calculation? How many of you have ever said, what is the best ordering size? Too often, we're just told, you will do annual tenders. You will do annual procurement. No one's ever tried to calculate what the economic order quantity is. What is this best balance? And that's the real problem, trying to get to a stage where we can get the system into balance, balance between procurement and between inventory management. But why is that a problem? Why can't we make this calculation? Well, often in the public sector, we simply have no data. If I ask the warehouse manager, what's the cost of your warehouse? Very, very few know. If I ask a simple question, what's your electricity bill for the month? Oh, I don't know, the government pays that. What's your water bill? Oh, I don't know, the government pays that. How many staff do you have? We probably know. What are their salaries? Oh, I don't know, the government pays all the salaries. We don't have the basic costs to be able to make the calculation. And if we look at the academic papers that are published around public health sector, we see they don't have the costs. Nobody has the costs. They have to estimate what the cost is. And they estimate often at around 25% of the value of the stock is the cost of holding the stock in the store. So again, if I work with the procurement unit, I ask them, okay, how much money would you save? How much would it reduce if you bought more quantity? Well, we don't know. We only do annual tenders. We don't have a quantity price list. So in the public sector, we often don't have even the most basic data to start making this kind of calculation. And that's a situation that has to change. So in procurement, why are you using annual tenders? Well, the most common reason is because we've always done it that way. Or the Ministry of Finance says we have to, or it's a government regulation. We haven't chosen annual tenders as the most economic cost option. We haven't chosen it as the best. It's just happened to us from history. Now, I'm not against annual tenders. Annual tenders can work. The point is, we've never chosen them. And that's the difference. If I look at the chart on the right, you see, as I order more frequently, I reduce the volume of stock. If I go from 12 months at the top down to 4 months at the bottom, I need much less stock. That means I can have a smaller warehouse, fewer staff, fewer distribution problems and issues. But I have extra procurement costs, and the cost of the goods will be higher because I'm buying smaller quantities. We make the balance on the graphs on the bottom left. You can see 12 months, and at 6 months and at 3 months, a vast reduction in the amount of stock. So procurement time and inventory management are completely interlinked. Annual tenders, why are we doing annual tenders? Well, They're not always wrong. They can be useful, but it's not been determined that that's appropriate for us. And why are we buying everything, every item on annual tender? Perhaps some items would be better being bought every 3 months, and other items could be on 12-month annual tenders. We're looking at one size fits all, one big lump annual tender for everything. And that's because of administrative convenience, not because of anything to make procurement supply chain management work or anything to benefit the healthcare of the patient. And that situation must change. Annual tenders can also have negative aspects. Very high stock holding level. I need to hold 12 months supply in my warehouse. I need this huge warehouse. And that's a problem because often I don't have enough space. A lot of storage space, some of the stock can become damaged because I don't have enough good quality storage space. I need a lot of money at one time to pay for the tender, all one payment off a huge tender. So lots of issues around that. Again, I'm not against annual tender. I'm against using it without having selected it as the best method. Well, if annual tendering is so good, why is it that nobody in the private sector uses annual tendering? Oh, they use tendering, but they don't use annual tendering. They value flexibility and time, speed of response, far more than just administrative convenience. To them, they want to factor in what is the cost of tendering? How much does it cost you to have all this tender committee, all these people for weeks adjudicating the tender? We don't consider that. And even if I ask a country, what is the cost of your tendering? Well, we don't know. Well, you have a tender committee of 10 people who meet for 3 weeks to adjudicate the tender. What's the cost? Don't know. What's the cost of delays in receiving goods? What's the cost of not being able to change to the latest products that are available because you've got 12 months stock of the old product? In the private sector, they value this flexibility, but fundamentally, they have a different approach to risk management. The public sector is highly risk averse. They don't want any risk at all, whereas the private sector recognizes that in order to get the best costing, you have to take some risk and you have to manage that risk. That's the important part. You don't just accept the risk, you manage the risk. And that's the key difference between public and private sector operations. So if I try and summarize this, if I use annual procurement, I need high stock levels and I need high buffer stock. If I'm not going to get any supplies for 12 months, a lot could go wrong. So I have to have some safety stock, some buffer stock in case something goes wrong. That's high levels of both, and that means high holding costs, big warehouses, lots of staff to manage that. If I look at schedule purchasing, that is, I'm going to do it on a set time period. I could buy weekly or monthly or quarterly or biannually. And the inventory impact depends how often I buy. If I buy weekly, I need very little stock and very little buffer stock because I've got new supplies coming all the time. If I buy biannually, twice a year, every 6 months, I need quite high stock because it's 6 months supply, and I need high buffer stocks because a lot can go wrong in 6 months. If we look at the other procurement method, which is perpetual purchasing, I don't wait for the end of the year. I buy whenever I need to. So whenever the stock level comes to the reorder point, I immediately buy. Now that's a much more complex system to operate. It means procurement are continuously buying. They're buying all the time, every time I get to the reorder point. but it's a highly responsive mechanism, and I can have low stock levels and low buffer stock, and that's what's used in the private sector. The sort of middle ground is I can have drawdown frameworks. That is, I place a contract for 3 years, but I only get delivery every 3 months. And I can alter the delivery quantities over those 3 months. And that gives me quite a lot of flexibility. So I've got the reliability of a long-term contract, and I've got the flexibility to adjust the quantities every 3 months. So the key message from this first little presentation is that procurement affects inventory management, and inventory management affects procurement. They're completely interlinked. Okay, our first Q&A session, if we have anything in the chat box. Stop sharing for a moment so I can read the chat box. Okay, I've got request a copy of this presentation. Yes, all presentations, the slide deck will be shared with you, and there is a recording of the entire webinar will become available. Okay, your chance to ask questions. Does an informed push model work? And does more automation assist to link procurement and inventory management? Okay, I'll take the second part first. More automation generally helps us collect data. And so it's the data that helps us interlink the two organizations together, procurement and inventory management. Automation of itself doesn't necessarily make it easier, but generally it provides the data. And it's the data flow that makes it easier. Does an informed push model work? That's really a distribution model rather than an inventory management model. And so it doesn't really affect procurement so much. But yes, push models can work, and they are better in certain circumstances. There's no one size fits all. It depends on the individual circumstances in your country. And we'll be talking more about that in module 6. How can we highlight this to senior management? We've been trained for 30 years to highlight this. It's not new to senior management. Part of our role for you is it's not enough that you know what to do. You have to be able to explain it to others and advocate for what we need. What are the alternatives you advise for the public sector besides annual purchasing? Calculate what is the optimum purchasing time for you. Put all the factors together, collect the data to allow you to make that calculation. Then make the calculation of what is the best procurement time for you. It's a split, it's a balance. There's no set time for every country. We're using tenders now, annual tenders, only for administrative convenience. They were convenient for the colonial powers doing government administration. They weren't convenient for the patients. They weren't convenient for the supply chain. We have to try and change that and bring a patient focus. More often, the problem is government health institutions where there is always a shortage of supplies, manpower, and there are rigid policies. Yes, it's these rigid policies on procurement. Procurement does need strong guidelines and rules, but often they're there for no reason. Annual tenders are not a sensible rule. Tenders are a sensible rule, but they don't have to be annual. And different mechanisms should be explored, and countries calculate, using all their factors, which mechanism is best for them. Can we still procure items for a program which are not consumed because the distribution area is facing a conflict? Very difficult decision. On balance, I would say yes, but it's a difficult decision and you need to look at all the factors. We have a separate module for conflict zones, which will become available, I hope, after you've completed the course. There is e-procurement or e-catalog. Does that help? It can help, because e-procurement can make perpetual procurement easier. And the e-catalog can help because that also brings around perpetual procurement. So on the e-catalog, individual hospitals and clinics order online, and it comes directly from the supplier to them. That can help a great deal, but fundamentally, you need to have the procedures which allow e-procurement and e-catalog. And that typically takes about 3 to 4 years just to get the legal constraints removed to allow you to operate. Indonesia operates an excellent e-catalog system. Thailand has got e-procurement, but it took many years to establish it. Give you another 5 minutes on questions if we have any questions. If you prefer, you can unmute and ask the question. Is it possible to apply economic order quantity in vaccine stock management? Yes, it is exactly the same, and you can find the same calculations. However, again, the problem is always, do you have the data to be able to make the calculations? Can we get the PowerPoint presentation? Yes, again, the link's already been shared with you, but everybody gets the link for the PowerPoint presentation, you get it. Vendor management inventory is limited. That's again because of archaic regulation. Vendor management inventory is not a universal panacea. It doesn't work for every country, but it can be useful. It can be useful for some items. A number of countries use it especially for laboratory items. There are around 400, 450 essential medicines. There are around 5,000 laboratory items. Trying to undertake inventory management on the laboratory items, clinical laboratory items, is exceedingly complex. So sometimes vendor management inventory can be very beneficial. However, it depends on the individual circumstances of the country. You have to make the analysis. Procurement of donated pharmaceuticals can be different from purchased items. Yes, it can. But when you get a donation, do you ask how many shipments? You get all the donation at one time. Is that helpful to you? Would it be better if you got the donation every 3 months? Would that make more sense? Global fund procurement, why are you ordering 1 year's supply? Why can't you have delivery every 3 months? Would that make more sense? You'd get better shelf lives. You'd have less stock to control and manage. So there are different ways to look at it. Again, for donated supplies, take charge. Go and speak to the donor. Tell them what you want. It's not just, the donor doesn't matter too much if you want 1 year's supply or 1 year's supply in 4 shipments. To them, it's not an issue. Go and ask for it if that's going to make it easier. And you determine that by determining your economic order quantity. And to do that, you need to be collecting data. What's the cost of your procurement? What's the cost of your stock holding? In conflict areas, we see a lot of unplanned emergency procurement. Yes, and that's unlikely to change, I'm afraid. In very high conflicts, often we're reduced to supplying kits. Kits are the only way to go. But if you still can use loose items, then yeah, there will be lots of emergency procurement. It's a feature of the environment. Increasingly, a number of relief agencies are using regional hubs. International Federation of Red Cross has a hub in Dubai, so they can supply countries from their regional hub. They can supply small quantities very quickly. UNICEF from Copenhagen, again the same, a regional hub. They can supply small quantities, very useful for conflict zone situations and emergencies and disasters. 2 minutes left on this question session. Okay, everyone's overawed. No one. How a donated program can advocate to facilitate the import permits and duty waivers. That's really a little bit outside inventory management, but okay. It really is having direct contact with government. Sorry, I'll just. Okay, I seem to have lost her. I'll come back to you in a moment. Okay.
I guess there's some technical issue with Andy sir. Let me just check with him.
Greetings, I hope I'm back with everyone now.
Yes, Prof.
Good, okay,
Yes,
then
sir,
we'll.
we can hear you well.
Okay, looks like we got some problems with the internet today. Okay, then let's go on to the session 2 because time it gets along. Yep. Okay. Okay, so what's the fundamental problem we have with inventory management? Well, as some of you already asked in the question box, there is virtually zero recognition of the importance of inventory management outside the supply chain. We really have to advocate much more strongly for what we're doing. Also, the cost of stockouts is largely unknown. We'll talk more about the methods of calculating that in later modules. But just so that you know, we refer to a system called DALI and QUALI. So DALI's disability adjusted life years, QUALI's quality adjusted life years. And that tells us the cost of saving a life and what happens when we run out of stock. We run out of stock of a critical item, somebody could die. Sorry, can I ask everyone to mute, please? Okay. And again, the problem is how many of you have calculated what the cost of an out of stock situation is? If I was out of stock of injectable insulin, somebody could die. What's the cost of that death? And usually we don't know, but those calculations have been done, and in later modules we'll introduce this concept of QALY and DALYs so that we start to understand what the cost of a stock out means in the care of a patient. In order to understand our inventory management, one of the first things we have to do is define what service level we're going to try and achieve. What is our target service level? And to define service level in its simplest form, it's if I request 20 products, how many of them can I actually issue? And if I can issue 200 items, I can issue 170 out of 200 items, I would have an 85% service level. So when I have a request, how much can I actually provide? That's my service level. And what's our target service level going to be in the supply chain? So in inventory management, all the time, we're trying to get this balance. The balance between having enough stock so I don't run out and not having too much stock so that I get expiry. And on the right, you can see this very complex formula for calculating the stock out costs. Don't worry, we don't have to use that kind of formula in PSM. Just be aware that they are there and those formulas exist. And even if we could do all the mathematics, we don't have the data to put into that formula anyway. But understand, there is a cost of a stock out. And we've not been good at articulating that. A patient dying is a cost, but it also has an economic cost to the country. And keeping that economic cost is important. So really, in inventory management, we're trying to balance 3 different factors: the ordering cost, the carrying or the holding cost, and the cost of stock outs. And I'm trying to balance all 3 together. So to do that, I'm going to set a target of my service level. Many private sector pharmacies set a service level of 95%. They don't always achieve it, but they set the service level at 95%. How many of you have established a service level for your supply chain? What's the service level in your country? And I would say that 85% of countries have never done it. They don't have a set formal statement of what their service level is going to be. For different items, we should have different service levels. It's not one size fits all. We've talked about Venn analysis before: vital, essential, necessary. For vital items, that is life-saving items, we should try for a service level of 98, 99%. For essential items, we can have a lower service level, perhaps 90%. And for the N, the necessary items, 85% service level would be good. It's not important if I'm out of stock of antacids. Nobody dies from indigestion. If I'm out of stock, it's bad, but it's not a major life-saving event. If I'm out of stock of insulin, that really is important. That really is a life-saving event. So I should try and set service levels according to the kind of item. And we use the Venn system: vital, essential, necessary. The problem with that is, too often, we have a minister who will stand up and say, I want 100% service level on every item. There is no system, no country in the world that can achieve that. And even if you could, you couldn't afford to do it anyway. And I'm going to explain what I mean by that. Basically, in order to achieve a particular service level, I need to have some safety stock. I need to be sure I've got some stock in reserve in case something goes wrong, extra consumption or late delivery, or there's a problem along the way. And I normally set that safety stock as being the lead time. And what we mean by that is if my lead time from placing an order to receiving the goods is 3 months, then I'm going to have 3 months safety stock. So in addition to the stock that I'm going to order an extra 3 months, which will be the safety stock. So fundamentally, my basic safety stock is the lead time. That's the formula that you all did in modules 3 and 4 around quantification. Okay? But there's no service level in that formula because that's the basic formula. We then come to the adjustment factor when we look at a slightly more advanced version of the formula. And we apply AJ, which is an adjustment factor. Calculating AJ is very complex, but basically requires that you have good stock records and you measure the variability. How variable is your lead time? Well, normally it's 3 months, but sometimes it can be 4 months and sometimes it can be 6 months. That's quite a big variation going on. So I'm going to add some extra safety stock because of these variations. And I do that using AJ, the adjustment factor. So if you thought that maybe your figures are plus or minus 10%, I would use an adjustment factor of 1.1. That is, I would order an extra 10% buffer stock. So I would have the lead time buffer stock plus an extra 10% buffer stock. That's all simple enough, isn't it? Yeah. But the problem with this is the relationship between service level and buffer stock is not linear. And what I mean by that is, as I increase the service level, the amount of buffer stock I require goes up very steeply. And I'll show you that on a graph. Here's the graph. So if I have my lead time, I will get a service level of around 84% using the lead time buffer stock. So if I want, sorry, can I ask you to mute, please, if you can all mute? Yeah, good. If I want a service level of 90%, can you see now, I need double the amount of buffer stock. And if I go up to 99%, I'm going to need 4 times the amount of buffer stock. So my buffer stock is 3 months, 4 times, 12 months buffer stock. Can I actually have that much safety stock? Does it make sense to have a whole year's supply of safety stock in the warehouse? So again, we come back to this need for balance between the service level and the amount of safety stock. If we look here with a service level of 84%, I use a factor of 1. That is the lead time buffer stock. If I order the buffer stock to be the same as the lead time, I will get a service factor of 84%. If I want 97%, I will need 2 times the lead time in buffer stock. And to go to 99%, I will need 3 times the lead time in buffer stock. So if my lead time is 3 months, I would need to have 9 months buffer stock. That means I'm ordering almost double. If I'm on annual tenders, I'm ordering 12 months stock and an extra 9 months buffer stock. That's the impact of service level. And that's why we have to be careful when ministers start speaking about 100% service level. We have to try and advocate and educate and bring the message of reality and the need for balance. Again, I don't need everything to be at 99 or 97%. the antacids are not critical. They could be at 84%. If I was out of stock for some days on the antacids, it wouldn't matter. It's not that important. On the insulin, it is vital. Somebody will die if I don't have it. So that needs to be a 99% service level. Different service levels for different kinds of items. And again, a chart giving service level and the lead time buffer stock factor. So 99%, 3.09 times the lead time in safety stock. So ask yourself, how did you determine how much safety stock to order? And most of you, it will have been set for you because you've always done it. You probably got 6 months buffer stock because you've always done 6 months buffer stock. You've never made the calculation. And our message to you in this module is start collecting the data to make the calculation of how much buffer stock is sensible in your environment. Few people understand this relation between the service level and buffer stock and the need for money to pay for the buffer stock. If I need 3 times as much buffer stock, where is the money going to come from for that buffer stock? Where is the warehouse space going to come from for that buffer stock? And the hard reality is, even if I calculate I need 3 times the lead time, I don't have enough money in the public sector to buy it anyway. And the result of that is I can never achieve high service levels. I'm always going to be out of stock because I can't get the funding to buy the safety stock that I need. And that's a key message that we have to advocate to decision makers and across the board. So annual tendering with high service levels is never possible because I can't get enough safety stock in the system. It also depends where I place the safety stock. And again, often we don't think about this. We keep the safety stock at the central warehouse. Well, that's okay, but it's not the best use of the safety stock. If I've got 3 months buffer stock and I place 2 months buffer stock at the province, I could be out of stock at the central level because I only got 1 month buffer stock there. But I wouldn't be out of stock at the province. So the patients wouldn't be affected. So placing the buffer stock closer to the patient gives me greater security. Having a high buffer stock at central level does not give me a good security for reducing stockouts. It needs to be closer to the patient. Always try to put the safety stock closer to the patient. If I only keep 1 month buffer stock at the health facility, I could easily be out of stock. This is not good because I'm keeping all my buffer stock at central level. Try to get the buffer stock closer to the patient. Then there's less chance of stock out. It doesn't matter if central level is out of stock for a few days because central level is not treating patients. The health facility is treating patients. They can't afford to be out of stock. So try and put the safety stock closer to the patient. Now, one of the many problems we have is our data is not very good. And we have all these variable consumption patterns going up and down. How can we make any sense of it? Here is a real life consumption pattern. And you can see the blue ones are the actual. And 1 month it's very high and the next month it's very low. Where's the sense in it? How do you get this? This is for antiretrovirals. The patients get the antiretrovirals every month. You don't suddenly lose the patients. You might get some more, but they don't suddenly disappear. How is it gone down to this level? That kind of erratic consumption is regrettably normal in our public health supply systems. And we have to try and use different methods to average out, to allow for this kind of variation. But recognizing we have this variation means I adjust my buffer stock. This is the adjustment factor, AJ. Look at the kind of variation I've got. I can't be very confident in my data. So I'm going to increase the amount of buffer stock by the adjustment factor for this kind of variation. For example, in the Eastern Caribbean service, they use 1.5 times the buffer stock because they feel that their data is not very reliable. So they balance it, they've made the calculation, and they use 1.5 times the lead time for the buffer stock. Different places depends on how variable your data is, how reliable your system is. And it's this need for data. We don't have it in public sector systems. Every private sector system has it because they recognize the need for data. Service levels have not always been considered, and we haven't made the balance that we need to make. We've got to balance with procurement time, we've got to balance with the service level. Try to bring a balance of the service level and the safety buffer stock that we need. Remember, we can use the Venn system. We don't have to have the same safety level, the same service level for every item. The vital items, high service level, high safety stock. The N necessary items, low service level, about 85%, low buffer stock, just the lead time. How do I calculate it? Here is a formula from the Harvard Business School. Don't worry, we don't have to do it. If we ever have to make this kind of calculation, the computer will do it all for us. The point is, recognize it's complicated. Recognize in order to make all the calculations, we need good data. And our first step is to collect good data. What's the cost of our holding? What's the cost of our procurement? When we've got that basic data, we can start making the calculations. Why can't we use these models in the public sector? Well, we can, except we don't have any data. And the public sector has never recognized the value of data. In the private sector, they do. They will invest in data collecting systems. Don't worry about these complicated formulas I'm showing you. I'm only showing those to demonstrate how to explain what we're doing, how the interlinking works and how complex it is. All of that kind of formula will be done automatic in automated systems, in computerized systems. If we have a good LMIS, Electronic Logistics Management Information System, it will make those calculations for us. But the first step is having good data. It's a bit depressing. It's really quite upset people, I'm sure, to be talking like this. But I want to give some hope. And that hope, surprisingly, comes from COVID. Because the COVID pandemic has really brought home to government ministers and all the donors the importance of inventory management and the fragility of the public health supply chain. And they're now taking much more notice of what we're doing and what we're saying. And they're willing to invest. There's new funding sources available. There's more procurement through donor systems. There's a wider range of manufacturers available. There's a massive change in regulations taking place. And the really good news is there's more money for supply chain operations. So my concluding message is it's full of hope. We've been through very difficult times. COVID has really shaken things up, really made people focus on the supply chain and how fragile it is. And I hope that that's going to bring us a lot of change in the future. I can stop sharing now. Okay, and we can go to our Q&A session. see what we've got in the chat. Can I get the link for the PowerPoint? Yes, yes, it will be provided. I would like to link with graduates living in Ethiopia. You can use the chat forum on the Empower website. The chat forum will link you with everyone. So if you have questions, please type them in. You can have comments, observations. If you say, well, it's not like that in my country, I'll be very happy to listen to you and hear from you. If any of you have got an established service level for your inventory management, I would love to hear from you. If it's easier, you can just unmute and talk. If you want to raise your hand, we'll try and get you unmuted. I welcome all comments, observations, questions. See, we have over 60 people in the forum, so I would have thought some questions. Okay, if you want to raise your hand and you can just talk rather than type it in, that's okay as well. I think everyone's a bit stunned by a very fast presentation. Yeah, okay. Okay, basic problem with the public sector is getting an accurate and workable service level projection. Most statements on this are policy statements and not backed by action. Yes, that's unfortunately true, but even if we start with a clear policy statement, that doesn't work unless we're measuring. Are we measuring what our service level is? And that's easy enough to do. We can just take 20 items, see what the requests were, see how many we were able to fill. So if somebody ordered 200 items and we could send all 200, our service level is 100%. We need to make that kind of measurement at each level of the system. And that's simple enough to do, and we should be doing it. And our logistics management information systems should be doing that. Agree that data collection is key, but what if it becomes difficult to get? Is there room for estimating? Well, we can take the middle ground, which is to do it by survey. Take a survey of 3 or 4 health centers or 3 or 4 hospitals. How many patients receive the medication? So how many patients were dispensed the medication? We can measure the service level that way. We can measure what's available of a list of 20 tracer items. Are they available at the health centers? Just using that simple measurement, just 20 items. See if they are available. We can get an estimate of the service level that way. It's a good start. It will help us in the beginning to help set a realistic service level and to advocate for more funding to improve the operation. It's fine to talk if you want to. If you want to raise your hand, we'll try and unmute you and you can just talk to ask the question. The normal safety stock is the lead time. Please explain more. Okay. So if we take our average monthly consumption, how much of this item do I use each month? I then multiply that by the lead time, and that gives me the basic safety stock or buffer stock, different word, but basically the same. The basic buffer stock is the lead time. That is the amount I would use in that period. The lead time is the time from placing an order, a contract or a purchase order, to receiving the goods in the country. So if I order it today, when do the goods actually physically arrive in country? And that's generally between 3 and 6 months. If we take 6 months, my average monthly consumption is 10, 6 times 10, then my safety stock is 60 items. That's the basic formula. We arrived at that because that gives us a service level of about 85%. Now, the longer the lead time, the more safety stock I need. If it's taking me 1 year from placing an order to receive the goods, then my lead time safety stock is long. That's difficult. But for most, it's between 3 and 6 months from placing the order to receiving the goods. That would be my lead time. I multiply the lead time by the average monthly consumption for that item. And that is around 84% service level. To go beyond that, I have to increase the amount of safety stock I have to allow for all the variations that can occur. In supply planning, are there other tools? Yes, there are hundreds of tools available to you. The problem is most of them are not specific for supply chain, and very few of them are specific for public health supply chain. M-Supply is an excellent tool that's available. Pipeline is an excellent tool that's also good, although it can be rather complex. Quantimed for quantification, lots of tools available. The difficulty is often we have got ELMIS, which is not supply chain. That sounds a bit strange. How can a logistics management system not be supply chain? Because it's a finance package. It's written for finance. It's very good for keeping track of all the money. It's not good for keeping track of the supplies. So we need ELMIS, which is specific for public health. And there are good systems available. There is a review of all the different software that is available from USAID. You can find it online, and we'll be referencing it in the next module. To get accurate data is a challenge because the manual processes through limited automation. Yes, I agree. How many of our warehouses have barcode scanners? How many of our provincial stores? Do any of our health centers have barcode scanners for the stock? We're trying to control the system manually. We know the smallest shop, they've got a barcode scanner and an electronic till. Why are we still using this 50-year-old technology of paper and pen to record items? It's becoming impossible. We need to move and greatly automate our systems. Automation on its own won't work. We have to improve the systems with the automation. And then we can have data. And once we've got data, we can start having evidence-driven decision-making and good management. Are there examples of systems where stock out costs were accurately measured? Yes, in the USA and throughout the private sector. You'll find it throughout Europe. They measure the stock out cost because the stock out cost is measured in morbidity, how the patient suffers illness, and in mortality if the patient dies. So very crudely, the cost of a death in Africa is reckoned to be about $25,000. So the cost of a stock out of a life-saving medicine, if it gave rise to one death, would be $25,000. What's the cost of having the material on the shelf? Well, if we take a life-saving drug like antiretroviral medicines, it's about $10 per month. Having it on the shelf, the cost is $10. Not having it, the cost is $25,000 because the patient died. It's always greatly in favor of having stock. So that's the message that we bring around calculating the cost of stockouts. It's always better to have stock. What's the cost of having anti-snake venom? It costs around about $100. What's the cost of not having it? A child dies, $25,000. 100 to 25,000, the ratio is clearly in favor. But it's not just about money. We have to think about humanity and caring for patients. And that's why we're in this profession, to care for patients. And that's what we try and do in public health, procurement and supply chain management. What are the best ways to conduct a system? Well, it's a little complicated because in some countries on stockouts, they do try and cheat computerized systems. So stockout would be zero stock. Yeah? In some countries, they keep one bottle on the shelf. There's always one bottle in stock. Then it doesn't show up on the computerized report of zero stock. So it's not a stockout. So we have to put in little formulas. And the formula we normally put in is that we have less than 1 month stock. It calculates as a stockout. Less than 1 month stock. For health centers, some use half a month stock, 2 week stock. Less than 2 week stock calculates as a stockout. And that gets rid of this idea of hiding your stockouts by keeping one bottle on the shelf. Okay, we have just 3 or 4 minutes left. Remember, you can send us questions at any time. You can put questions in the chat forum, on the course forum, or you can send them directly through. And if you have any particular problems or issues, we'll always try and give you a direct face-to-face consultation. Okay, just 1 more minute then, and I will close the webinar. And if you have particular subjects you want to cover in the next webinar, please send your suggestions in. Next webinar is for module 6. That'll be the prime focus, but we can find a little time for any specific questions or areas in modules you've already covered. Is there an acceptable safety stock level in systems with several supply chain layers? You do the calculation, basically, keep it to the lead time. If you've got, what's the lead time for your supply chain layer? So from the health center to the district, when the health center orders, what's the lead time to come back? So again, the safety stock, we come back to the lead time. For central level, it's procurement. For other levels, it's ordering. From when I place the order with district or with province, state, what's the lead time to receive the goods? From the health center, if my lead time is 1 month, then I would keep that as the buffer stock, 1 month buffer stock. Similarly, if I'm district ordering from province, if my lead time from the province is 2 weeks, I would keep 2 weeks as the buffer stock, the basic buffer stock. I am in the northeast, West Syria. Okay, of recent, we have been working on requisition tool for health facilities. Our procurement period is 1 month. We use the formula of quantity to order is 5 average monthly consumptions minus current stock. Okay, divided by 3, given that our lead time is 10 days. Okay. I'm a little bit worried about 5 average monthly consumptions. That seems excessively high to hold 5 months stock. 5 average monthly consumption. Okay, quantity to order, divide by 3. Okay, I'd be a little concerned about that. I think it's a little bit high. For a 1 month period, it's not the procurement period. Yes, I think it probably is a little high. even though you're dividing by 3, 5 divided by 3 would be 1.5. Yes, I think you could perhaps reduce slightly on that. If your lead time really is reliably at 10 days, the question there is your lead time reliably at 10 days? So if the answer is yes, you could reduce the formula a little bit. If the answer is it's not reliably 10 days, then I would stay with the formula you have. Okay, I see there's 1 minute to go, so it's time for me to stop now. Thank you very much for joining us today. If you have any suggestions for next time, if you have any more questions, please send them in. Okay, Priya, any final words from the Empower team before we close?
Thank you so much, sir. It's always a pleasure to have you as an expert. Thank you so much for your time. The PPT, the slides and the recording of the session will be sent to you soon, by Monday probably. Okay, and I have already sent you the PPT on the chat, in the chat. So please, you can just take a look. And if you have any questions regarding the session or any questions regarding this module, please feel free to reach out to us and we'll get back to you soon. Thank you, everyone. Thank you, sir.
Okay, bye now. Namaste.
Bye.
Priya.
Thank you.
Yes, I can hear you.
Yeah, this is Odol from South Sudan. How are you?
I'm good. Thank you.
Yeah, if you remember, last time I sent you the SWIFT transfer through the email
Yes.
because I wanted to resume my studies. And
Yes.
I'm still waiting until now. There was no any reply from you.
Yeah, we are going through some technical glitch, so I will get back to you and we can discuss further on a call. I'll call you after this session.
Okay, thank you. Thank you. Bye-bye.
Premier. Hello.
Yes.
Mine is an inquiry and I should have done it off-site, but I'm taking this opportunity to inquire. When you submit your final case study, how long does it take to get a response?
As soon as you submitted your final case study on the portal, we forward it to our SMEs, and the SMEs generally take 15 days to grade the assignments. So your assignments I've already forwarded to the SME, the subject matter expert. We will update you with your grades soon. I need to check with him. If you have graded your assignment already, I'll update you as well.
Thank you. And when is the next graduation?
We are working on it. It will be probably the end of December month or the first week of January. We'll let you know with the final date as well.
Thank you.
Is there any further questions?
When is the next intake? So that we recommend some of our colleagues interest them in the course, the next intake for
Sure.
the postgrad diploma.
You can send your applications. Please ask them to fill the application form, and as soon as we get the application form, we'll let you know and we'll enroll you in the course.
Okay. Do we have like country-specific alumni associations of graduates of Empower School of Health that you know of?
Not exactly, but please write down me an email. I will look into a query and I will assist you. I will help you out with this.
Because I also saw a colleague asking for alumni from Ethiopia. Myself, I'm from Uganda, but
Okay.
I just Yeah, I just wanted to, because on the platform, I don't see, on the website, I don't see a lot of engagement with the alumni.
Right, exactly. What we can do for your colleague, just ask him to send me an email, and I will check with my former graduates if somebody's belong to that country. So I will try to schedule a call between them so that he can ask his queries with them.
Oh, okay.
Okay.
Thank you once again.
So then, allow me to end this session. I will get back to you soon. If you have any further questions, please feel free to email. Please feel free to email me. Okay, I will get back to you as soon as possible. So thank you all for joining in. The slides and the recording of the session will be sent to you shortly. Thank you.
Thank you. And bye-bye.